Welcome to the Health Workforce Tactical Assistance Center's webinar series. This presentation is entitled Health Workforce Minimum Dataset, Asking the Right Questions. And it was presented by Jean Moore, Elizabeth Carter, and Justin Crowell on November 19th, 2014. Before we get started, I'd like to introduce you today's presenters. Dr. Jean Moore is the director of the New York Center for Health Workforce Studies at the School of Public Health, State University of New York at Albany. She has over 15 years of experience conducting research studies on a wide array of health professions, including physicians, RNs, and advanced practice nurses. In addition, Dr. Moore has studied health professions regulation and its potential to constrain scope of practice for many health professions. Dr. Elizabeth Carter is the Executive Director of the Virginia Board of Health Professions. She has held this post since 2001, and before that she served as its Deputy Executive Director beginning in 1994. Dr. Carter also heads the Department of Health Professions Healthcare Workforce Data Center, instituted in 2008. Her responsibilities include overseeing policy research and advising on issues pertaining to the regulation of health professions, healthcare workforce, strategic planning, and agency operations. Justin Crowell is the Deputy Executive Director of the Virginia Board of Health Professions and the Deputy Director of the Healthcare Workforce Data Center. Justin performs policy research for the Board of Health Professions and manages the HWTAC's data system. Now, at this particular point in time, I'm going to go ahead and turn the event over to our presenters. After the presentation, you may ask questions using the chat panel on the right of your screen. Make sure you send your questions to all panelists to ensure that they have an opportunity to be answered. Also, when the presentation is completed, you will be directed to a short evaluation survey. So please take a few moments to fill it out. Jean?
Thank you, David. So the presentation today is on Health Workforce Minimum Dataset, Asking the Right Questions. And an overview of today's presentation, I'm going to provide some basic information about HRSA's Health Professions Minimum Dataset. Essentially, what is it? How do you use it? And that's going to be followed by a presentation by Liz Carter and Justin Crow to really give a good state example of how they developed a health workforce monitoring system that included the integration of MDS questions, and then give some examples of how they use their health workforce data and analysis to inform policy decisions in Virginia. So just to give you a little context, I think that there are a number of key health workforce issues that planners and policymakers really need information about. And three major areas are supply and distribution, the educational pipeline, and demand for workers. So this webinar will focus on the issue of supply and distribution, needing to know how many do we have, where are they, what do they do, when will they retire. So again, we're focusing on supply data and how minimum data set can support asking the right questions. So basic health workforce supply data can be used for a variety of things, and these are just a few very brief examples. So again, being able to pinpoint where health professionals are, where they're not. The supply data can be used to build stronger supply-demand forecast models. And particularly important, it can inform the development of health workforce programs and policies and evaluate the effectiveness of those that are operating. I think everyone recognizes that many groups collect health workforce supply data. Federal agencies, including HRSA, and the two things that come to mind for me when I think about HRSA is the National Sample Survey of Registered Nurses, the National Sample Survey of Nurse Practitioners. Many state agencies collect data, specifically licensing boards, state workforce centers, state nursing workforce centers. Health professional associations collect data, including the American Medical Association, and from there we get the AMA master file. Health professions board associations are also involved in data collection. Health profession certification organizations, and one noteworthy one is the National Commission on the Certification of Physician Assistants. The NCCPA was involved in data collection that allowed them to capture a really good amount of information about PAs across the country. But there are concerns about the quality of current workforce supply data. Sometimes there are differences in fundamental questions that are asked in surveys of health professionals. So while everyone agrees that certain questions are really important to ask, sometimes they're asked differently, and sometimes that can limit the comparability of data across different data sets. And there are also issues around timeliness, completeness, and accuracy of the data. So the National Center for Health Workforce Analysis prioritized the need for a minimum data set. And essentially, NHWA recognized the value of identifying a small number of key questions that are critical for effective workforce planning and recommending standard approaches to asking these questions. And I will tell you that NHWA built on the work of other groups engaged in health workforce data collection, many health researchers around the country, as well as groups like the state nursing workforce centers. So what is the Health Professions Minimum Data Set? Specifically, it's a set of standard questions that are recommended for use by all groups who engage in health workforce data collection, focusing on the supply of workers. The questions focus on characteristics in three key areas: demographics, education, and practice. And it provides, if you follow the MDS, it can provide basic information on health workers that can inform planning efforts. I will say, though, that it's really important to recognize that groups that collect health workforce supply data typically go beyond the minimum data set questions, and I'll actually give you some examples of that. So what are the demographic questions included in the MDS? So the core questions are birth date, gender, race, ethnicity. And again, recognizing that sometimes groups who are collecting data need other information, optional questions on state or country of birth, language fluency. In New York, in our re-registration surveys, we typically ask, where did you attend high school? And I will tell you that that question stems from the great interest in understanding the health professions education pipeline and the extent to which we're growing our own health workers. Education questions, the core questions are around entry level and highest level of professional education, information about licensure, certifications and specialties as applicable. Optional questions can include the name and location of educational institutions. In New York, many of our re-registration surveys ask where people, what schools people attended when they completed their professional education, and there's just interest in the contribution of individual health professional education programs to the state's health workforce. Practice questions. Core questions include employment status, number of positions, hours by activity, practice setting, practice location. And really, this is key to identifying professionals who actively provide patient care. There are optional questions about patients served, whether Medicaid, Medicare is accepted, practice capacity, whether new patients can be accepted, and retirement plans. What do you plan to do next? So again, uses of data from the Health Professions Minimum Dataset, these are a number of examples, but there are certainly many more. But again, the basics of supply and distribution by setting and location, which is really important particularly for state planners and policymakers. Assessing primary care provider capacity, and I will tell you that it's critical to think about looking beyond physicians and considering the provider capacity for NPs, PAs, midwives. Understanding the racial and ethnic diversity of health professions, particularly in relation to the diversity of the population served. And there are also opportunities to do profession-specific research studies on things like, characteristics of health professionals who practice in underserved communities. I think it's important, as anybody who is going to be engaging in health workforce data collection, you need to plan your starting point, and that really starts with the question, what do you want to know? What are the key research questions that will be answered using these data? And to be candid about this, I think that depending on the questions you want to answer, you may need to drill down a little more and get a little more detail depending on what you want to know. So if you're doing a primary care capacity assessment, you're going to need more detailed information on physicians, NPs, PAs, CNMs. You'll want to know the specialty of the practitioner. If there's a supervising physician, you'll want to know the specialty of the supervising physician and the specialty of the practice. You need practice address and hours worked by practice location. This essentially can enable you to identify who is practicing primary care, where are they practicing it, and you can actually calculate FTEs by practice location. So for a comprehensive primary care capacity assessment, these are the sorts of questions you need to ask, which typically go a little deeper than the MDS recommendations. But again, you got to start with what do we need to know. Another interesting group is the public health workforce. And I think that a public health workforce enumeration typically has to look beyond what's in MDS. I think that knowing an occupation of a public health worker is important, but then you need to know things like public health specialization area and what the job functions are within that area. I actually worked with a group who developed a public health taxonomy that started with MDS and built out from there, saying if you're going to do a public health enumeration, what are the sorts of things you might want to consider including in your survey that will be useful in your analyses. So in closing, here are some useful links. HRSA's MDS webpage that actually drills down and provides information about the sorts of questions that, or examples of the questions that can be asked. The work on the public health workforce taxonomy that was just released in a publication. And another interesting report, which is a profile of PAs in the U.S. that came from the NCCPA based on their efforts to integrate MDS questions into their certification, recertification process, and provide some pretty detailed information about PAs across the country. So at this point, we will turn it over to my colleagues, Liz Carter and Justin Crow, who are going to talk about how they've taken these concepts and applied them to their work in Virginia.
Thank you, Jane and David. We very much appreciate the opportunity to share with you lessons learned, if you will, in Virginia. Let me tell you, first of all, we are housed of Uh-oh, hold on. David, can you forward our link here? Are we good? Is it coming?
Yeah, I can hear you.
Can you hear me?
Yes, we can hear you.
Oh, good. All right. Okay. There we go. Thank you. We're housed within the Virginia Department of Health Professions, and we're relatively unique in that we have 13 licensure boards, health licensure boards here. We're housed administratively here. We have computer systems that we share, and that has gone a long way in us moving toward developing a minimal data set approach because, again, we share all of our resources together. I can go down the hall and talk with the Board of Nursing or Board of Medicine, dentistry, and so forth, and I just wanted to let everybody know that up front. Yes. Sorry, Justin.
Are you ready?
I'm ready. Yes, go to the next slide. We began our journey actually in the mid-2000s at a time when it was growing concern over an unprecedented demand expectation with a decreased supply in vision. We knew that even before the Patient and Protection and Affordability Care Act was passed, that we'd have a large portion of Virginia's healthcare providers actually are baby boomers, and that the pipeline behind was smaller. We also knew that we were having a growing population and an aging population, and Justin will go into a little bit more details of that a little bit later. As I indicated a little bit earlier, we're the natural data repository for over 80 professions, over 350,000 actually now, licensees. We have an online licensure renewal and application process, and so it made it it's relatively easy for us to include the workforce surveys here. And in 2007, a Governor's Commission on Healthcare, he did recommend that we create the Healthcare Workforce Data Center within the Department of Health Professions. The following year, the next 2 years, we had Workforce Investment Act grant funding, which helped us to establish it a little bit. And even more important, we had legislation passed in 2009 that enabled us to ask the questions. I'm not sure all the states have legislation that would allow them to ask the questions, but it is crucial that you get that. It authorized not only the data collection, but it protected the confidentiality of that data, and it allows us to share it with qualified researchers, with proper MOUs, institutional review board kind of review and that sort of thing. Our mission is to make sure that we improve. Head to the next. Okay, that's it. I'm sorry. Just skip forward. Is that we, improve the data collection and the analysis and so forth. In 2010, a couple of things happened. There was a HRSA workforce implementation grant that Virginia won. This is a $1.93 million grant. We didn't get all that money, but as part of it, it helped to support the Healthcare Workforce Data Center staffing a bit and also some of our resources. We also had a Board of Health Professions under that big umbrella agency. There's representation on that board from each of the licensing boards, 5 citizen members, but there was a research staff already in place, so that if you're looking at it from a financial standpoint and from a policy informing standpoint. The original questions that we had came from 2 surveys, one from the Board of Medicine, which had been a little bit earlier. They had a requirement for that. And also from the Board of Nursing. They had developed surveys prior to the Governor's Health Reform Commission. And so we brought in national experts. We had a stakeholder group comprised of members of the General Assembly, from the Cabinet, from educational institutions, the professions, and so forth, that all told us, what those key questions that Jean was talking about, what are the things that we need to know about? And so that helped us to begin to sort of reform those surveys and to standardize them. And our current, if you go to the next page, sorry, the next slide will take, right now, between 2008 and today, you see the list of professions that we now have profession-specific surveys for, and they're all running. We have a host of publications that you'll see on our website at the end, and in 2013, we really geared up everything to become systematized, and so we've sort of pretty much standardized our procedures. And I'm going to turn it over to Justin now because he's our procedural guru, and thank you.
Thank you. This is Justin Crowell with the Healthcare Workforce Data Center. Yeah, I'm going to get more into the nuts and bolts of how we set up a data system. The first thing I'm going to talk about is what happened in 2007 when then Governor Kane, now Senator Kane, instituted a health reform commission to look at the health system as a whole, but they also looked at the healthcare workforce. And these are just a few charts that were available in that report. These are 3 charts that were in the executive summary. There was a lot of underlying data there, but this was the main thing. And I want you to look at some of the information on these charts. They all look very different because they are very different. If you look at the bottom left of the chart on the top left, the source for that one is the U.S. Bureau of Labor Statistics. The source for the other one, the one on nurses, was the National Sample Survey of Registered Nurses from HRSA. And the bottom one, we have a couple of footnotes there, but that's from the AMA Physician Master File and from the American Association of Medical Colleges data. So you have 3 different sources there. And if you look at what each of them measures, the first one measures jobs. That's what the BLS measures from the Current Establishment Survey. So what you're looking at there, you don't know if it's part-time jobs, if it's one person filling 2 jobs, or how many people are actually available to fill those jobs. It's the count of jobs. The second one looks at FTEs, which is a measure basically of work effort. So if you look at that, a nurse who fills a part-time job will be counted as 0.5 FTEs, a full-time job 1 FTE, a full-time and a part-time job will be 1.5 FTEs. And if you look at the bottom chart on physicians, it counts active physicians. So whether that physician works part-time, full-time, or has 2 jobs, they're counted as 1 physician. So as you can see, these are very good data sources individually, but they all measure different things. So what we wanted to do was create a data system. So this is with the Healthcare Workforce Data Center. This is just a snapshot of one of our tools, and I'll get into more detail on this later, but it includes 18 professions, the 18 professions we had at the time. You can see in the chart on the bottom left with the blue bars, it counts licensees and it counts FTEs and it counts them all the same way for each profession. We have more information on age and more information on gender as well, and even more information. So that's the difference between what I call a data collection effort, an effort to collect a lot of data, and an integrated data system where you collect comparable data. So how do we get from that in 2007 to where we are today? Well, we had to, at some point, develop a strategy. And our strategy was, because we didn't inherit that data collection system, as Liz mentioned, that had a bunch of disparate surveys. Because what we decided to do was we decided to focus on our core mission, which was to create research quality data. Now, a lot of times when you're setting things up, people want to go straight to analysis. You need the data first before you can do the analysis. And we decided to focus on standardization. A lot of what, as Jean discussed, is when we had concepts that we wanted to measure them the same way, ask the same questions so we can make apples-to-apples comparisons. We wanted to make sure that when we had other data sources out there that were good, particularly federal U.S. Census data, things of that nature, and other state data sources, that we could link to them. So we thought about them when we were developing our data system. We wanted an easy set of indicators about the professions that people could look at, that people could recognize, and that were consistent across professions and over time, and as you drill down are aggregated, the different professions together. And standardized reporting products that also people would be familiar with when they looked at them. And all of this, of course, and this was one of our goals, we have 1.75 FTEs here. It allows for automation, so it makes it a lot more efficient if you have it standardized. And if you see on the left here, these are basically what I use as an executive summary for our profession reports. You can see there's a standardized set of indicators. This is 2012 for physical therapists and 2014 for dentists. The exact same indicators for both professions over the years. So you can see how that can be useful to create trends on a number of issues, and I'll go into more detail on that in a bit. Okay. So the first thing you have to do is develop your measurement instrument, your questionnaire, and the minimum data sets that have been developed are very helpful in that. I do want to emphasize here just showing you how much details can very easily trip you up when you're developing this system and you're trying to get them together. We inherited, as I said, a data collection effort, a bunch of disparate systems, and just about every way you can measure effort, really what you're getting at is FTEs here, we found in those very small number of surveys. So if you're just going to ask, how much do you work? How many hours do you work? How many FTEs do you have? There are a bunch of things you need to think about. The time period you're asking about. Are you only asking about right now, or do you want to look at the past month or past year? What unit of measure are you looking at? Full-time or part-time, or hours per week? And if you look at part-time, if you look at that list there, you can ask about 30, 32, or 35 hours, but you can also mess up if you ask one less than 30 hours as part-time or one 30 hours or less as part-time. Someone who works 30 hours for each of those questions will be counted differently as either half or one FTE. And then when you ask the question, do you ask at the beginning of the survey overall? How much do you work, or do you ask for each separate location? Each of those will have to be calculated FTEs differently. And then even once you've decided on how you want to ask the question, you can see in the chart in the upper left, we have different ways of asking hours per week. We have to use drop-down menus. We can't do numeric systems because of our software. So if you do 10 through 19, that's different from asking 11 through 20 hours or 5 through 9 hours. And so the HWTAC came up with a peculiar system to use for that, for all questions. And this is something you can run into for each question, no matter how simple it is, whether it's gender, whether it's race, ethnicity, all of these questions, this level of detail needs to be considered for all questions. One of the other things we really looked at was linking to other data sources. Of course, one of the things that we really wanted to link to was the U.S. Census data system, particularly the demographic questions and the questions related to race and ethnicity. So we use that standard. That's also often a touchy question. We get a lot of complaints even about how we ask it here. We got one just the other day, actually. And it's always good to be able to point to, well, it's the U.S. Census system that we follow. And that's actually, it's an Office of Management and Budget federal standards that are used across all federal agencies. We wanted to be able to link to something called the North American Industrial Classification System. So when we ask about establishment type, do you work in a physician office, a dentist office, a hospital? We make sure that that matches to a code in that system. That's something we do ahead of time. You want to consider the administrative regions in your state. In Virginia, we use counties and independent cities for a lot of our local health districts, or our Virginia Community College System service areas, our workforce planning and economic planning districts are all based on county. But a lot of patient level data, particularly that collected by hospitals, they use the zip code as their standard aggregation level, just because that is the data that they tend to have. So that's something you want to consider. For automation is a very handy tool, not only because it makes it quicker, you can see some of the programs that we use here, but also because you're able to embed all those decisions you've made previously about methodology. How are you going to calculate FTEs? How are you going to define who's in the workforce? All of those questions, all those definitions, all those methodological decisions, you don't have to reinvent the world every time. They're all within that automation tool, the program, and it's all embedded there. Anyone who has questions about how you did this or how you calculated that, and whether you made an error, you can just provide them with the raw data. Well, not necessarily the raw data itself, but the automation tools, and show how you came to that conclusion. And of course, it does shorten your processing time from months to weeks. We can really do a whole survey in a week, just processing the data. So once you have all that down, then you get to do the fun stuff. You get to present the data. So this is one of my favorite things. These are a closer look at our CareForce indicators. These are the same boxes I showed earlier that I use as our executive summary for each of our individual annual or biannual professions reports, depending on our renewal system. As I said before, this is the 2012 physical therapist and the 2014 dentist. They're the same. And what I want you to focus on is the workforce indicators in the top left corner of each. You'll see we have 3 indicators on this one: the number of licensees in the state, the number of those who are in Virginia's workforce, those who are working in Virginia or available to work in Virginia, and then of course our FTE measure. And if you look at the bottom right, we have sort of the same thing. We have, how do they spend their time? We have how much time in patient care, how much time in administration, and how much are in what we call a patient care role. We had kind of 2 different names there, but it's the same concept. And then if you look at the bottom left-hand corner, if you drill down into our reports, you'll get even more indicators. So you'll see that the 2 workforce ones there, we report licensees in another section inside the report. And then we have something we call our utilization ratios, which are show how effectively you're using those workforce licensees per FTE and the number of workers you need to create an FTE. And as you drill down into our reports, you get, of course, even more detail. All this is comparative. This is a demographics look at dental hygienists. So you can see even more indicators there, and then we have even more detailed tables. If you look at the race and ethnicity table, you'll see the Virginia population, so that kind of shows how you can compare to that U.S. Census data right there. We have a couple of quotes that our communications director suggests we put in there so the media can just pull those out if they need to. And we have a few charts and graphs, but this isn't really the area for charts and graphs. This is where we just present those CareForce indicators. We do have a lot of fun with charts and graphs, and I'm going to switch over now to, if I can get this, there we go.
There we go, yeah.
To some of our charts. Now, this is a tool. Let me know if you can't see this for any reason. This is the tool I created to help students who are in school and when we're looking at health professions, choose that health professions. You see that chart at the top there? It has each of the professions listed. The colors are the amount of education you need from high school with pharmacy technicians to doctorates and residencies with physicians and dentists and other professions, and then income. We have another little tool, a little lower. This is interactive, but you can do the same thing in reports, you know, on paper, but you can really quickly look and see, having all this same data, you want people to be able to look at, they want to say they want to earn $50,000 a year and they only want to go to school for 6 years. There's a list of the professions with the projected growth rate from the BLS and medium income and then the size, and we can do the same thing on all of our indicators. We can drill down. Here's some information on education level and compared to income and years in school. Another similar chart that has income and education level. But that's kind of information you'd expect. But this is one of my favorite charts here at the bottom. It has job satisfaction level measured the same way for all these professions. FTEs, how much each student could expect to work in a week. This is our refreshing. I'm sorry about that. So if we do our $50,000 in 6 years of schooling, quickly look at which professions might have the highest job satisfaction and how much the student would expect to work, and then the circles are sized by job stability, the percentage that are employed over 2 months. So you might look really quick and see that physical therapy assistants have a high job satisfaction. They're not working overly hard. A lot of times they're not working 60 hours a week like some of our facility administrators are. And in the pop-up tool there, you can see that they only need an associate degree. So that might be a good choice for some students. But that's the kind of stuff you can do. You can also drill down by region. This is the slide I showed earlier. You can choose different regions. So this is our Blue Ridge region. You can also choose our AHEC or Eastern AHEC region. Oh, sorry, as it refreshes. And you have, as I said before, our FTE and licensee data, and also data on age, median age. Red is older, green is younger. If you look at the dentists here, you can quickly see that they are 55, the median age. Dental hygienists right below them, about the same number of FTEs, and but the median age is 43. So that might be information that could be useful. Right, and then you have the same kind of view. Dentists are almost all male, dental hygienists almost all female. So there might be some opportunities there to leverage that in the workforce arena. All right, now I'm going to return to, that's not it. That's not it either. Where did it go? Stop sharing. Here we go. All right, return to our PowerPoint.
And just so everyone knows, the software that Justin was using on that last part here, in addition to, of course, the SPSS and so forth, is Tableau, and we're using a free version of that, a public version. So it's not like it's an insurmountable cost to make this happen.
So, and that's just really how we present our data. That's really just descriptive statistics that we put out there for anyone to use. It's handy tools, basically. But we also get a lot of opportunities to do some actual policy research. So I'm going to show you some examples of what we've done in the state. My other hat is with the Board of Health Professions. I do a lot of scope of practice reviews for the board. One of the things we're looking at now is dental hygienists. So one of the charts I was able to include, we were able to look up just some background that Virginia has kind of a restrictive scope of practice on dental hygienists. They're not really able to work outside of a dentist's office as much as you would in some other states. So if you look at the chart in the upper left-hand corner, you can see that a higher proportion of dental hygienists work in dentist's office than dentists do. So that's some helpful information to note just how your scope of practice laws might be affecting the workforce. And because you ask those questions the same way from both groups, you get the same answer. And you're also able to show, where they work throughout the state with full-time equivalency units the same way. This is the same kind of report. Remember I mentioned the age earlier, the difference in median ages between the two groups, and we compare that with other data in the state. For instance, this is our degree bank data from our State Council of Higher Education in Virginia. You can see that the number of graduates from hygienists are coming out a lot quicker. So you can see sort of some opportunities there, maybe for some bridge programs for dental hygienists and dentistry are different things you can do if you're struggling with your oral health workforce. Those are just some examples. I'm not suggesting that, as a policy choice. I don't make those decisions. I just pull out the data. Another thing we're able to do, a lot of states in the country are debating Medicaid expansion. Virginia is one of those states who are still debating it. And last year, our General Assembly asked us to develop a look at the primary care workforce. We were able to do that across professions. We were able to pull out by specialty and for physicians, physician assistants, and nurse practitioners, those who worked in a primary care specialty and those who accepted Medicaid, and get a really good look at the primary care workforce, for legislators in the state across those professions and drilling down into those professions at the same time. So we aggregated 3 professions and we drilled down at the same time by specialty and by whether or not they were accepting Medicaid. And we can do that for all of our indicators, really. All of our indicators are very fungible and very flexible in that way. We did another study. This is our Pathways to BSN, and if you work a lot with nursing, BSN is a very important issue, but we're able to show how nurses advance through their career using education. And if you ask this for each profession, you can do the same thing. How does your health workforce advance their careers through education? From associate, are they moving up in degree levels? If they come in with an associate as a PTA, do they move into physical therapy or some other occupation at a higher level? Or, how does that work as stepping stones? You can look at that. And because we did compare it with that census data, you can see the chart in the upper left looks at that advancement by race and ethnicity. And we're also able to look at it by administrative regions in the state, in this case our AHEC regions, and see whether rural areas or urban areas or whether target areas are improving. Whether if you also include school locations, you can see if a school is having a good effect or not. We're also working with our Virginia Perform system. Our Virginia Perform system is a report card system in the state. It measures everything, all kinds of things that you can imagine. But one of the things they look at, this is the workforce system report card. It has a lot of different measures, but I want you to look at the brown box on the right-hand side. That's the emerging workforce in manufacturing. They created that last year. They're adding an industry a year, and this year they're adding the healthcare industry. And so they're incorporating some of our data along with our VEC, our Virginia Employment Commission data, and some of our educational system data to create a workforce, a healthcare workforce report card system. So those are another use of the data. Some other projects that we're assisting with are our university in Hampton Roads, Old Dominion University, does a State of the Region report every year, and we're providing them with a comparison of the nursing workforce by MSA. They have asked for all of our care force indicators by MSA, so we're going to provide that to them. I think that will be very useful for all the MSAs in the state. We work with our Virginia Healthcare Workforce Development Authority. They have an online mapping tool, and we provide data for that, and the link to that is there. And they are also using our data to perform about 8 or 9 regional supply and demand analyses throughout the state. So our data will be the supply side data for that analyses. We coordinate with our Virginia Department of Health on creating shortage designations. We don't do that here, but we do provide the data for shortage designations. And we also worked with our NOVA Health Force, which is Northern Virginia Health Force, and a report done by them in Jobs for the Future looking at the state of the healthcare workforce in Northern Virginia. So another regional supply and demand report that was done a couple of years ago. Okay. The next few slides, these just have some links to our data products. So if you want to take a deeper look at what we have here, they're available in some brief descriptions. I'll just leave those up for a minute. Okay. And thank you. That's just an overview of our data system and how we use our data, and we'd be happy to answer any questions you have, and thank you for having us today.
Yeah.
Hey,
you went through a lot of you at one time.
Thanks. That was a really interesting presentation, and thank you, Jean. Justin, I believe this one's for you. A point of clarification. On one of your slides, I believe I saw a diversity index.
Yes.
Can you tell us a bit about that?
Yes, that is something that the U.S. Census Bureau came up with a couple of years ago, and it's basically the best way to describe it is if you have two random people meet, the chances that they would be of a different race or ethnicity. So that's what that means. And if anyone is interested in how to calculate that, I could send that.
We have the methodology too. That's on our website.
Or you know, on our website we have a methodology and glossary that also has how to calculate that. It's not very difficult. Squares and square roots.
Okay, thank you. And just a reminder to our attendees, these slides will be available on our website after the presentation, maybe shortly afterwards, at healthworkforceta.org. Now, with that said, another question. Are your surveys voluntary or mandatory?
Actually, the statute makes them mandatory, but we've considered them voluntary as best. We've been getting pretty remarkable response rates. It's in the 70s all the way up to the 90% response rates. And this is, for some of the professions, year in and year out. We've had like 2 or 3 years for some of them. So we've been very fortunate. Health workforce is a key issue, not only, you know, for the policymakers, but for the practitioners themselves. And so, you know, they're very interested in helping us with this, and we thank them every time we meet with the respective boards and produce the reports and so forth. But yeah, so we don't force it. It's part of the license renewal process. You kind of run to our survey before you hit that last button, but there is an opt-out, and we've been very fortunate, like I said, to get good responses.
And one of the things with that being voluntary is that we don't have a census. It's not a census of all the practitioners, so we do have to make statistical estimates. We use a weighting system to make statistical estimates of each of those indicators and for the population as a whole.
Age and rural.
Yes.
Okay, here's another question. With so many women in the healthcare workforce, how do we measure women coming in and out of the workforce to have children, or women working part-time?
That is interesting, an interesting question. We do ask, I mean, there are different ways to do that, but one of the things that we do ask is how many weeks you worked in a year. And of course we have gender as well, so we could look at that and compare it to men and just see if, especially if you also compare it to age, we could probably take a pretty good look and see how that is affecting the labor supply and how that would affect FTEs. And other questions about that, whether women do re-enter, but we don't look specifically at people leaving for family medical leave, that type of those type of questions.
But we can look at the trends over time of how people have, at different ages, are working.
Right. Yeah, we could definitely look at the trends over time on that.
Okay. Just remember, everybody, we didn't. I'm sorry. I was going to say, remember, we didn't start till 2010 doing this.
Well, we'll give you a few more years to get it all in order then, right? Actually, this is a very interesting monitoring system you have set up. And just kind of in general, how much does it cost for launching and maintaining this monitoring system? I know you mentioned that Tableau, you're using the free version of it, but can you be a little bit more elaborative? Because I know a lot of people out there are very interested in what you're doing.
Actually, initially, as I mentioned earlier, we did have some grant funding to establish the center and try to, sort of get our, have the meetings and so forth. But at this point, we're combined with our Board of Health Professions, and it's the largest part of your budget will be due to your staff. And so you know, we operate with less than about $400,000 a year doing all of our policy research as well as the Healthcare Workforce Data Center piece of this. In terms of the computer systems, I would have to get back with you on that one because our bill is not, it's sort of incorporated within the department overall. When we can get a particular grant or here and there or are invited to do certain things, we take advantage of what can be attained that way from meetings and so forth, but we really don't have a large number. The money is not that much, is what I'm trying to say. Justin, do you want to speak about the part-time person?
Yeah, well, basically what we have is we have 3.5 FTEs here, 3 full-time people, Liz, myself, an operations manager, and a part-time research assistant. And these people are split with the Board of Health Professions. So we do it with 1.75 FTEs. And a lot of the standardization and automation that I spoke of, that was a lot of the impetus for that. When I undertook this at the beginning, I saw what we had in front of us and what we had to do and the number of surveys and the amount of information that we needed, and the automation became pretty much imperative. And so that's how we've really been able to maintain our efficiency, collect a lot of data, and have some time left over for analysis and for some ad hoc custom work as well. So,
and the SPSS software is our biggest software expense, and that's about 4,000 per person.
Yeah, 4,000.
It's about 4,000 per unit on your SPSS. But so, I mean, again, I think we get a big bang out of the buck that we are using.
Okay, thank you, Liz, Justin. I have one for Jean now. In your practice sections, there is no mention about telehealth. Is that something that's going to be coming in the future?
I think that interest in telehealth is growing dramatically. I think as we struggle to figure out how to expand access to services, particularly in rural communities, there is more and more interest in developing telehealth strategies. So I realize it's not in the practice questions now. I think as states develop workforce surveys and identify telehealth as an optional question. I mean, one of my first questions is this only something we ask physicians? And to be honest, I don't think so. And I think that sometimes it's important to look at some of the providers, such as FQHCs, and do surveys that help us understand how they're using telehealth and how they'd like to use telehealth and what the barriers are. So again, I think it's an important issue. I think we can certainly track use among different health professionals, but again, I also think that providers, particularly those providing a large amount of service to underserved populations, particularly in rural areas, need to be engaged in helping us better understand this. Liz, do you have any thoughts on this in terms of the work you've done in Virginia?
I think it certainly can be a question that should be added. In fact, our Board of Health Professions at its last meeting was talking about the impact that telehealth will be having. We need to start looking at those very issues. Absolutely.
Right, and we have had a couple of our professions themselves ask for telehealth questions, so a few of our surveys do include those, and we may be expanding on that to make it a standard question for all the professions that would work in telehealth. So.
All right, thank you. Next question. With the Medicaid acceptance data, was that self-reported or based on claims data?
Ours would be self-reported. Now, we do have another, of course, we do have a Medicaid group in the state, and concurrent with our analysis of what the data that we had, which was in our survey, self-reported Medicaid providers, a study was done, and with using that DMAS data, that billing data, which is obviously, we think, better. A lot of people are providers, but a lot of people don't necessarily really have a lot of Medicaid patients. So that billing information is going to be better data, if you can use that.
Justin, I'm inclined to agree with you. So we have a question on our physician re-registration survey in New York around estimates around the percent of your patients who are Medicaid, Medicare, et cetera. And, you know, one of the things we've noticed is that we think that there actually may be some underestimation of the Medicaid patients in managed care. So we have access to claims data, and we're actually trying to triangulate the two to better understand what our physician estimates, and we do believe they're estimates and may not be perhaps as accurate as we'd like, but then actually looking at the reality of the claims data and what that tells us.
Definitely.
Okay, next question. This one's from Europe. At the EU level, we are struggling to collect data on health workforce through the OECD WHO ILO questionnaire. There are mistakes in the categorization of nurses, which lead to inaccurate data and doesn't allow effective planning and forecasting. How do you get around this in the U.S.? Options, solutions?
So let me just say that from some of the international work I've been involved with, there are categories of nurses that are at times somewhat confusing, and so I can easily understand how things could be miscategorized. You know, I'm interested in Liz and Justin's reaction, but I think that one of the strategies we use in the U.S. is, so we have the licensed practical nurse, licensed vocational nurse category is a discrete category from registered nurse. Within registered nurse, we have a couple of different categories related to educational level, as Justin presented on one of his slides. And then at the higher end, we have advanced practice nurses, and they are broken out by certified registered nurse anesthetist, nurse practitioner, clinical nurse specialist. So some of it, I think, is making sure that you've got categories that really match, you know, who people are and what they do. I will tell you that, you know, so in workforce data collection, that is probably the best strategy. When we look at things like census data through ACS, where people are asked to self-report, oftentimes we see misclassification, and a lot of times when you look at education level and then the selected occupation, you begin to understand where the misclassifications may come from. Liz, Justin, any thoughts on that?
No, and I think you're right, Jean. I also think one of the things that we do, of course, here is that we focus on getting the licensure, your licensure status. We have separate licenses for nurse practitioners, for CNAs, CRNAs, and so forth. And so we use that because that tells you what your scope of practice is, what you're allowed to do. What you may be doing in addition to that, you'll use the other surveys to supplement it, but our focus, because we are so focused on the license side of things, that's our world.
Okay, thanks for the answer. This question's also for you, Liz and Justin. How did y'all get stakeholder buy-in to create this data system?
I'll take that one, I guess. Okay. Well, for one thing, when you have a governor say you will go do this, it doesn't hurt. And I think there are a lot of folks in healthcare industry, in education. Everyone is interested in healthcare issues, and I think it wasn't a hard sell to say, could you come and sit down at a table and help us figure out, how to approach this problem? Because as we know, we're all aging, it's a growing population. And these problems are real. They're not academic exercises. And so we thought we'd have to pay them at first. We didn't. They all came for free. I brought them cookies and some tea, and they sat around the table and they actually formulated, they brought the key questions. They prioritized what they believed to be the most pressing issues, and they reviewed the surveys that existed with national experts and so forth. So we didn't have trouble getting people to come. I was very well impressed by just how people cared about this issue. And so that's my short answer.
I think you see it reflected in our response rates as well. There's a real real interest in this kind of information from the professionals themselves. They really really want this information and really appreciate it when you have products that you can put out that they can use and understand. So I think that helps.
It was a win-win.
That's a good answer. I think I want that cookie recipe, however.
I'll get you that.
Oh, thank you. With that said, do you get requests from industry or business for data?
Yes, we do get occasional requests from different organizations. Liz worked in the past with the Virginia
Hospital and
Healthcare Association, which is our industry group for hospitals and healthcare facilities, on a statewide workforce analysis that they did. We get a lot of requests from educational institutions, both public and a lot of private, who are looking at expanding programs. They either want to expand programs and are looking at the workforce itself, or they want to know what is happening to their own graduates, which is something we can get at if we combine it with some of our administrative data sometimes. But we generally don't respond to those because of our mission is a public health mission, and it's really looking at those public questions. And at this time, we respond to some when we can, but normally we are looking at questions from the General Assembly or from coming down from our Secretary of Health and Human Services, or for grants in the state, and some of our partner agencies is where we really get most of our work from.
It could change in the future, but this is where we are now.
Yes, but there is demand out there from businesses and industries for this type of information, definitely.
Okay, thanks. I think we have time for one last question. What advice would you give to states who may just be beginning the process of collecting workforce information from licensees?
You may take that. This is Liz. I would recommend not trying to reinvent the wheel. Honestly, I think what the power behind the minimal data set, our version or whoever's, we need to start asking the same questions the same way across all the professions, across all the states, so that we can truly understand the ebb and flow of people, because you don't just work in one state, you go all over the place. So I think, use what we have. Go to that website that we have up there. We're happy to share our questions with anybody. It's not, we're very open about everything that we have. Always take phone calls, email us, let us know, but that's how we learn. We started asking questions of North Carolina and New York earlier, and so it helped us as well. So this is a sort of a collaborative thing right now, but use what's already there and then build on that. And you have deliverables. You can show them.
All right. Thank you, Liz. Thank you, Jean. Thank you, Justin. It was a great webinar. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.